Good evening, everyone, and welcome. It's another Tuesday night. It's just gone 8 p.m. My name is Fahim Shakur, and I'm joined along with my regular co-host, Mehran Javed. Tonight, just before we begin, the phone numbers for today's show, the usual ones. The studio number is 01282723455, and the WhatsApp number is 07522723455. Tonight is a continuation in some ways of the dental program that we did back in June, nearly 5 months ago, and there was so much interest in that show, so many questions that we did decide that we would do a second show. A lot's happened in the 5 months since then, and so we're going to discuss all of that. And please do write in and actually text us all of your questions to do with dentistry tonight. I'm going to now hand over to Mehran to actually introduce our lovely guest for the evening.
Great, thank you, Fahim, and thank you everyone for tuning into MEDtalkx radio show. Just be mindful that we are broadcasting live on our YouTube as well as Facebook platform. So without further ado, let me introduce Dr. Seby. You may remember him from our 2nd of June show. So he is the lead dentist at Hewetts Dental Surgery in Huddersfield. He graduated with honours from Sheffield University in 2004. He's been finalist on numerous occasions on dentistry awards, and he's also the treasurer for the West Yorkshire branch of the British Dental Association. So I think your practice is pretty big, isn't it, Dr. Seby? I think 12,000 patients, is that correct?
There was at one point, I would say it's probably a little bit less than that now. But yeah, we've expanded from 5 surgeries up to 7 surgeries literally within the last 6 months. So yeah, I mean things are changing very, very rapidly. So yeah, it's a big surgery. 7 surgeries is classified as quite a large surgery.
Yeah, fantastic. So I guess we've got to try and address the COVID-19 situation. So when we discussed last time, you were quite in the thick of it, and I guess we still are quite in the thick of it. So how has your practice had to adapt to the change?
So I think last time we spoke, we were basically going through all of the protocols, the new protocols that were going to be in place. So dentists were kind of sidelined in a lot of ways because they were looking for the government for support and guidance, and it came through very, very slowly in dribs and drabs. And dentists had to take a lot of initiative themselves in terms of procuring the right equipment. So one was an equipment issue. So we needed specialist equipment, in particular, pretty much builders masks, FPP3 or FPP2 masks. You may have heard of these. These are a level above the masks that people are wearing in the streets, the medical masks. And we needed to procure those, know how to use them, know how to disinfect them, know how to take them on and off. So not only was there an equipment issue, there was also a protocol issue that we had to work around. Dentists, luckily, are at the forefront of sort of cross-infection anyway. That we deal with that on a daily basis. So it just required a little bit more imagination, some guidance from various sources, and eventually we've got ourselves into a situation. I think last time we spoke, it was my first week or two in the thick of it. We're now a few months into it, so I think we've nailed everything down. We've gone over any teething issues, we've gone over protocols, had lots of staff meetings, lots of training involved, risk assessments. So it's been a bit of a minefield as a practice owner. Legally, you've got responsibilities for your patients, for your staff, and yet you want to get people out of pain as well. So it's a bit of a balancing act, and I think we're on that sort of tightrope, really precariously balanced, so to speak, but we're doing the best that we can.
Yes, great. And I guess some people may have some confusion whether dentists are open at the moment. Are you guys open, and when do you think appointments will kind of return back to normality?
Yep. So all dentists should be open for sort of routine care as well as more advanced care if needed. Some are still going through the protocol, still procuring, although I'd say that they're probably in the minority now. I think the majority are pretty well kitted up to see their patients. we're also guided by the systems that we inherit. So, for example, I'm a private practitioner. I don't necessarily have to abide by NHS rules and regulations. I can sort of do things a little bit freer, which opens up the protocols and everything else that I can follow a lot easier, basically. The problems that patients may be having are to do with procurement, possibly protocols. Second, if the dentist is a kid up, but more often than not, it's because of the new procedures taking a lot longer. So their day lists are clogged up. So dentists are clogged up with patients that they would normally see, I don't know, 20, 30 patients a day. They might only be able to see 10 a day at the most. So that's clogging up the list. And as you can imagine, waiting times then go up unless the dentist has taken extra measures. So the extra measures, for example, that we've taken at the practice have we've got basically air quality engineers in the building to fit some specialized fans within the surgery. So what that does is effectively it sucks the air out, and I've got that running almost all the time now. And whenever we do anything that involves spraying in a patient's mouth, we put it on full blast, and that allows us to take that clearance time within the surgery down to 10 minutes or 15 minutes. Whereas if you didn't have that installed, it would be up to an hour. So you can imagine that will clog up your day list just for clearance and clean down after patients have been.
Seby, I want to ask you more about COVID. Obviously, there's so much to explore. So let's continue down. I was on the BDA website, which is the British Dental Association. It's really interesting. Yep. I've not been on it before. They have like these daily updates, and they were talking about dealing with difficult patients if you go on today's, and they were saying that some dentists are coming across patients who don't want to follow government guidelines because you have to wait outdoors. I've been to the dentist during the pandemic before you called in, and the weather's getting colder, obviously. You got mask wearing, PPE use. The price has gone up for many appointments, I think it's fair to say, which you can talk about. How are you dealing with the price issue and making sure patients are happy with what you're providing, and just general unhappiness with patients coming to see you with the things that I mentioned?
Okay, so I mean, to start off with, we had a lot of goodwill with patients. You've got to remember that obviously healthcare workers, and I hope that dentists were included within that for various reasons. But healthcare workers were held to quite a high esteem. People were clapping for them on Thursdays, asking for pay rises for these people, and rightly so. So I think patients were, on the whole, have been very, very patient with us. They understand that we've got to work in very close proximity to other patients. We're risking our lives in many instances, and we're trying to get people out of pain, trying to keep them as healthy as possible. So I think on the whole, patients have been really good. But there are one or two sort of outliers, anomalies. Patients who are dubious about coronavirus or are anti-establishment. They don't want to follow any rules. I've only come across one or two of those. And we've got a strict policy in-house. I'm not going to risk the health of my staff. I'm not going to risk the health of any of the patients that are in the building. So if they refuse to follow those protocols, they're not going to get in the building, basically. So that's just the be-all and end-all of it. There's nothing. I can't get into a prolonged debate. I don't have the time to, in terms of why we're doing things the way that we are. In terms of sort of the cost of things, I think dentistry and cost, it's always been a bit of it's been a bit of a funny subject, really. I don't think dentistry follows other healthcare professions in that respect. Doctors, and we had this argument last time, if you remember, whenever you go to the doctors, you're never charged. So you guys win every single time. You guys might run half an hour late, and the patients are still probably thankful. Whereas if we run half an hour late, they're like, well, knock off 10% off my bill. It's kind of like they're going to buy a product rather than they're actually visiting us for our expertise in our healthcare. But if they weren't taxed in such a way, whereas where they wouldn't get it free at the doctors, would the same response be true? I'm not sure. What do you think, Ben?
I think that's lends itself to a can of worms, which if we get time at the end, we'll explore. But definitely, I completely agree with you. The cost thing, that's just society now. If you're paying for something, you expect it. And it'd be the same if it was a private patient in medicine, I think, as well. You'd expect some, in private practice. But obviously, we work in the NHS, so it doesn't apply in that sense. I guess the other question, you've talked about the difficult patients, some of the difficulties, and also access as well. Because, in general practice, we have been seeing patients with dental problems coming along, asking for telephone calls, dental abscesses, sedation maybe, things of this nature. People going to out of hours because they may have not been able to get a dental appointment. I mean, what do you say about some of these issues, and are they resolved, and how should healthcare professionals and the public behaving around these sort of issues?
Yeah, I mean, I'll tell you what, I mean, in terms of the new patients at my practice, for example, we normally on average see about 30 to 40 new patients a month. That's how many we on average used to see pre-COVID. Now we're seeing treble that, I would say. Honestly, we're seeing 70, 80, 90 new patients. A lot of those patients that are coming to us are ones that have been away for years. So it's not, I've seen my dentist 2 years ago and something's happened. It's 10 years, it's 15 years. I've never been to the dentist. And these are the people that have been bouncing off A&E and doctors and bouncing to and fro between those people, getting prescriptions, getting them by on, just getting them by on painkillers and prescriptions. But now, because of COVID, I think what's happened is that the access to those areas is so strict and it's really tightened up that they have no choice. The doctors are saying, no, actually, you do not belong here. Don't come here if you don't need to. Find yourself a dentist. And they're actually forced down that route at a time when it's really hard to get in with a dentist. So it's all kind of coming together in a bit of a bottleneck. So I do feel for these patients, they've had bad experiences, they're nervous. There's various reasons why they are the way that they are. But you know what, with the right professional in the right team, often with sedation or other measures, but quite often not, just talking to these people and doing things in a very slow manner. Dentists are often stuck on a treadmill where they're seeing patients really quickly. And, it's not the way that I like to work. And, if you just sit down and you talk to people, it's surprising how much headway you can make with these patients. You can do all sorts of complex treatments on them eventually.
So Seby, over the past few months, I think there was an article in the Times earlier this month saying in total about 15 million appointments have had to be cancelled because of the COVID pandemic with dentists. So how do we kind of address that backlog, or do we just say, okay, we have to reset the button and try to approach things on an as needed basis?
Yeah, so I mean, I think in terms of dental care, there was a shortage, particularly on the NHS. On the private side, maybe not as much, but on the NHS, there was always a shortage, a backlog, an inability to access. It was difficult as it was. I think now this bottleneck, I can't see an easy solution, to be honest with you. I can't see how it's going to be resolved. There's a whole host of patients that need to be seen. The timescales of seeing those patients, like I mentioned, the air that needs clearing out and the surfaces that need cleaning within a dental surgery before you see the next patient. Unless everybody gets these fans fitted and the measures and the protocols change, I can't see this ending for another 6 months to 12 months. I just can't see it. I don't think that it's possible. I really don't. I think what needs to happen really, and the NHS have hinted at that. The NHS have given new targets, and the new targets for this year is 20% of previous year's targets. So essentially, you only have to have 20% of your patient contacts. Now, I think what we have to do is reserve that for emergency dental cover, for one. That needs to be prioritized, and reserve it for things that would otherwise get out of hand. So something that can easily be done quickly, efficiently, and prevent a bigger problem later on. In terms of routine stuff, like we mentioned, how often you should visit the dentist. There's people that are very low risk category groups, and I think that they can wait. They could probably wait another 6 months. They could wait a little while we get through the backlog. So yeah, I don't think that there's an easy solution to it, to be honest with you. I really don't think that there's an easy solution. I think prevention, do what you can. That's always a lot of dental problems are preventable, whether it's decay and that's sugar related or hygiene and gum disease related. Those are the two common things. So prevention, And we talked about it on the show at some length last time, but prevention and making sure that we can do that and avoid visiting the dentist in the first place is probably the best spot call. But I don't think that they should end up with GPs and with A&E at this moment in time. So try and get in, and you may have to pay privately. Unfortunately, that's just the reality of it.
No, I understand. I guess the last couple of questions on the COVID-19 related tasks, and then we'll move on to some more core topics. So with difficulties means some opportunities for reform. Do you think that there are clearly some opportunities here? And I guess in addition to that, are we going to face a recruitment crisis in terms of the dental industry? Because, Brexit is around the corner.
Yes. So I think, yes, there is an opportunity for reform. The last time we had reform within dentistry was 2006, where a contract was given to dentists, and it was very target based. We thought it was going to be different to the previous setup, where we wouldn't be on such a treadmill and we would focus on prevention. And that never happened, really. I mean, we're supposed to be as preventative as possible, but we just don't have the time in the day to do that. If you work on the NHS, you're given so many targets, and it's almost impossible to square that circle, really. Are they going to do the same now? I don't think so. And the reason why I don't think so is that the purse strings suddenly haven't come loose, and we've not got a bag full of money. The bag of money is tighter. We all know that money and care kind of go hand in hand, and I can't see them saying, okay, work on prevention and we will pay you for prevention. Governments have a 4-year term, right? Prevention, to reap the benefits of prevention, it takes 10 years, 15 years to get that money back. So are you gonna say, okay, we're focusing on prevention now at a time when the economy is really struggling, when we don't have a lot of money even for healthcare? And suddenly that equation is going to change. For me, the equation just doesn't add up. Care takes time. It also takes a lot of money, a lot of experience, a lot of training to do it properly. It's particularly in healthcare. In healthcare inflation, as we've all noted, I mean, we're all buying masks, right? We're all buying gloves. We're all buying, disinfectants and things like that. Things that we have to use. And healthcare inflation, I don't know what it's running at, but some things went up by 2,000, 3,000%, and I can't see the equation adding up. You can't have a situation where healthcare inflation is rising so rapidly, the purse strings are getting tighter, and suddenly healthcare is open to everyone. In terms of recruitment, I don't think that there'll be a massive recruitment issue. Dentists, we do have quite a few dentists in the country, and there's lots of dentists that actually don't train, that are British, that train abroad. So they train in Bulgaria and various other countries, and then they come back to the UK looking for work. So there's a fair amount, and it's not saturated by any means, but I think it's kind of there, and it's stabilizing. It's more about the systems that we work under, and there's only two basic systems: private, and you pay for that, and it's expensive. The NHS, cheaper, but can it satisfy 60 million people? I don't know.
Yeah, no, it's a really thorough answer. Thanks, Seby. I want to come on to something else that's been going on in the pandemic, the concept of teeth grinding. I know we discussed this off air recently. Bruxism is the medical term. And it's a surprising new side effect of the pandemic. Dentists are reporting a recent rise in teeth grinding. Can you tell maybe some of the viewers and listeners as to what causes it and what can happen from teeth grinding?
Okay, yeah. I mean, anecdotally, so that's just my visual experience on a day-to-day basis, nothing set in stone or a study. I would say that it's probably increasing. I can't say that for certain, but it makes sense. I mean, people are definitely more stressed. But yeah, the effects of it essentially, so what happens in your sleep cycle is that muscles can fire, a bit like sleepwalking and sleep talking. It's a condition which affects. It's debatable. Some would say that almost every single person will grind their teeth at some point in their lives, and they'll go in and out of phases. So it's debatable as to how many people grind at any one time, and there's a variance in that. But the effects of it can be quite severe. So the forces that you can put on at night time are very, very high. During the day, you're aware of things more, and you almost have a feedback loop to pain, so you would stop yourself. But at night time, it's possible to put on some really immense power. And effectively, it can stress the muscles, it can stress the jaw joint, and it can stress the teeth and the foundations of the teeth. So them are the three things that can get affected. If it's the muscles, it can lead to muscle headaches. If it's the jaw joint, clicking jaw, locked jaw, pain in the jaw joint. If it affects the teeth, it can wear the teeth down, make them more sensitive. You can break fillings, break teeth, cause gum recession, foundations receding. So it can be quite detrimental overall, and it's often overlooked because it's so in the background. A lot of these things happen very slowly over time. It's not like something happens all of a sudden, so it can often be overlooked by professionals. But good to be aware of it, and there's treatment available. So see somebody who knows what they're doing and get it sorted.
Yeah, no, that's great. And the other thing that's been going on a lot, that maybe not a lot, but we've heard here and there, is things like people using pliers to take out teeth and so on, and really, quite graphic accounts. At first I thought it was just one person, but I've actually read it on a few reports now, where they just couldn't cope and things like that. I mean, what advice do you have to patients who are in agony and they get to that level of desperation? What are their options available to them?
Yeah, and I fear for this because these people, like in any crisis, unfortunately the poorest or the most vulnerable suffer the most. And it's fair enough for me to say I'm a private practitioner. I choose to be outside of the NHS for a few reasons, and I just don't think it works. I don't think politicians and managers telling me what I should do with the patient that's sat in front of me based on numbers and statistics, I just don't think that works very well. I don't think that I can do the best for my patient under that system. Now, the poorest and the most vulnerable, if they're taking things into their own hands, literally, I think it's a shame because I can't give any more advice than, I suppose, what we did over lockdown, which was online advice to say, take painkillers, here's some antibiotics, get in touch with your dentist, your local dentist if you're registered. They should have a protocol and a means in place to at the very least, virtually get in contact with you, if not in person. Go and see them. If you can afford the treatment on the NHS particularly, go ahead and get the treatment done. It's going to be basic treatment to start off with, probably a temporary filling or the tooth extracted. Nothing too complicated, so don't expect too much. But saying that, I mean, it's either that or you pay privately, right? I mean, this is the problem that we've got, and I can't see the bottleneck changing. So I wish I could help more, honestly, for him. I don't know what else to say. Painkillers, pain relief, over the counter. So ibuprofen works really well if you're okay to take it. 4 hours later, paracetamol, and alternate between the two. Add a bit of codeine if it's getting worse. So over-the-counter painkillers, and then if you need more than that, you really need to see a medical professional to be able to prescribe more, because that's probably the max you can do. And then antibiotics. We don't like to give antibiotics because treatments often work better in the first instance and avoid antibiotic use. So if I was to take the tooth out, that would solve the problem. If I was to dress the tooth, that would solve the problem. Put a temporary dressing in the tooth. So we often want direct access. Dentistry is one of those professions where you can't do it remotely. It's just one of those things that you just cannot do remotely very, very well. It's horrible, and I'm sure you guys are finding in medicine as well. There's certain things that you're kind of double, triple guessing, and you're trying to make. But really, you want the patient there in front of you. You want to examine them, and you want to see what's going on. You want to take an X-ray, or you want to do something that you can say definitively, okay, that's what's going on, and this is the treatment for it. And our hands are tied at this moment in time. It's not very good.
I guess, Dr. Seby, lots of people are complaining of mouth ulcers, and from not my own personal experience, but members within the family who have them find it quite excruciating. Is this one of the things that equates to a dental emergency, or is there some practical things that you can do at home to try and address the issue?
Yeah, so mouth ulcers, they can be different severities of mouth ulcers. So you can have some minor sort of mouth ulcers that come and go, and then you can have sort of major episodes. And some people suffer major recurrent episodes. If it's a minor one, yeah, it's something that you just live with, I suppose, and everyone gets them now and again. If they're very frequent, then it may prompt a dentist or a doctor or somebody else to get some bloods taken, make sure that there's no sort of deficiencies or anything that are contributing. A referral to oral medicine. They're the specialists that sort of deal with this area, particularly for the major types. Major types are big, huge ulcers that take a long time to heal, and they often leave scarring inside your mouth as well. So they really are a nuisance. For patients that are suffering that, I'm sure it feels like a dental emergency, but strictly speaking, with what's going on, I wouldn't classify it as that. I would say it's probably not an emergency. Is there anything that they could do at home? To be honest with you, not much works. I mean, a bit of salt water can probably help a little bit. Chlorhexidine, a mouthwash, has been shown just to speed it up the healing slightly. You could put Bonjela or something, some agent on top to try and relieve the pain, but again, regular use of those is not particularly recommended. It's a tough one. It's a tough one. I think it's one of those things that you just have to grin and bear and put up with. Oral medicine can give you sort of steroid mouthwashes for the major ones, so something like Difflam mouthwashes. Steroid mouthwashes can make a little bit of a difference. But yeah, it's a tough one. I would say oral medicine, your normal dentist, and then oral medicine if it's the major type. But relieving stress and various other causes that can often be warranted in these cases.
Because one of the things that is on the guidance is to have a soft diet, isn't it? To try and see if that actually helps alleviate. I think it's fair to say I think I would struggle with a soft diet. I think a South Asian diet in general would struggle with a soft diet. But how important is what we put in our mouth in terms of food stuff as well as fluids? Guarantees a good set of teeth.
Or generally, or more generally, with dental care, is that what you're saying, Aaron?
Yeah, maybe perhaps more generally.
I mean, like I said, dental problems are largely preventable, and it's either one of two things that cause it. One is what we put in our mouth, like you said, and more importantly, how frequently we put things inside our mouth, sugary things in particular, and the frequency of the sugar intake is the most important thing. So it's not the amount of sugar, and I said this last time on the talk, but literally you could have 20 Mars bars and eat them now within 10 minutes if you could, if you were quick enough. Let's say even if it took you half an hour to eat 20 Mars bars, that would equate to almost negligible damage to your teeth. Whereas if you had, let's say, a pack of Maltesers and you had the big jumbo packs and you were eating one of those every 10 minutes, what actually happens is that the bacteria in your mouth that are surrounding your teeth in plaque, they digest the sugar, and they don't need a lot of sugar. This is another thing. They don't need Maltesers, actually. Even dilute juice, no added sugar, dilute juice, very small amounts of background sugar floating around. But bacteria don't need a lot. They need a very, very small amount. What they do is they ferment that into, and they utilize that, and they produce acid as a byproduct. That acid increases the acid levels, reduces the pH in your mouth, and rots the teeth. Basically, you've got to imagine your teeth are like chalk. They can be eroded away by acid. That's essentially what they're like. It's tough chalk. It's like a tough chalk. So they get eroded away, and you end up with a cavity. So the frequency is the most important thing. You've got to give it at least an hour, 2 hours, 3 hours, 4 hours between meals before you eat something, if you can. Most of us can't manage that. But if you're going to pick something in between, let's say after an hour or two you're peckish, pick something savory, cheese toast, nuts, olives, hummus, breadsticks, those sorts of things. Try and avoid things that have natural sugars in them as well. So a lot of people have healthy diets and they still end up with a mouthful of rot, and that's from sugar, from grapes, fructose in fruit. And it's a frequency. So, a bunch of grapes could last you an hour. They could be sat there and, that's not a good way to eat them. The best way to eat fruit is with meal. So you're getting one sugar hit. If you're going to have some juice, have it with the meal. Even if you're going to have some Maltesers, have it with the meal. And then in between, water if you're thirsty, and like I said, savoury snacks. So it's the frequency that is, they usually don't have nice teeth. That's the problem.
Seby, we talked a little bit about mouth ulcers. I guess it lends itself going on to mouth cancer as well as a discussion point. And that can perhaps present in many different ways, including the non-resolving mouth ulcer. I mean, obviously one of your jobs as a dentist is to pick out mouth cancer early on, and I'm sure you probably check this at every checkup. Can you tell us a little bit about how mouth cancer to a dentist presents? And also in the context of risk-based checkups. There is an argument now that you don't need to see a dentist like every 6 months. There's evidence out now that perhaps it could be every 2 years, and statistics say that less than 50% of adults in 2019-20 year attended an NHS dentist in the previous 2 years, let alone 6 months. So in the context of frequency of checkups, what's best? And also in relation to, does it matter in terms of mouth cancer symptoms?
Okay. So in terms of, we'll start with mouth cancer symptoms, I suppose, in terms of what we see. So one is, yes, like you mentioned, a non-healing ulcer that's been there for maybe more than 2 to 3 weeks. Anything over 3 weeks, I would be suspicious of. The ulcer usually presents itself slightly different to a normal ulcer. So a normal ulcer might be yellowish in the middle and sort of have a red surround where it's inflamed slightly. But mouth cancer ulcers tend to often be painless as well, so they're not painful and tender. They tend to be very firm, so when you touch them, they tend to have a very sort of thickness and rigidity to the tissues themselves, whereas a normal ulcer will feel soft, just like the rest of the tissue. The margins of the ulcer tend to be rolled over a little bit as well. So that's quite a typical suspicious lesion, we would say, and we'd put you on to a 2-week referral at the hospital. So you're seen within 2 weeks, and they would often biopsy it. So they'd put a local anaesthetic on the area, and they'd take a little bit of the tissue away and put it under a microscope and find out what that actually was. So it often presents itself in that way. It can present itself in other odd ways as well, in the bone, for example. So you could take an X-ray and you could see a fuzzy area in the bone. So it can present itself on the skin, on the surface of the skin, even on the outside of the mouth, on the lips. It can look purplish as well. So there's some rare cancers that look a little bit purple. So that's how it kind of presents itself, but it's good to get it checked. I don't want everyone to panic over an ulcer now, but most of them are completely benign, absolutely fine, will resolve. But if something's been there for more than 2 to 3 weeks, I would say go to your dentist and get that checked. That's the time that you need to get it checked. In terms of frequency levels, so there are people that I would worry about more. So if you presented with an ulcer that was kind of half suspicious, but you were smoking and you were drinking, if you smoke and you drink, both of those things, and quite heavily, so let's say you're on 20 to 40 a day with the cigarettes, and you're on over 30 units of alcohol a week, maybe 40. We have 1 or 2 patients that smoke more than 40 a day and are on more than 50 units a week. Now that to me is just crying out for close observation. How frequently should I see that patient? I would not be happy seeing that patient every 2 years, for example. I would see that patient at least every 6 months. Now, in terms of frequency, it can range, and my range is 3 months to 2 years. You're right; it's about that. I rarely see anybody at a 2-year recall. Most are 1 year to 1.5, simply because of the mouth cancer issue. Most of my patients are over 40, and they fit into those categories where I think I need to keep a closer eye on things. I'd rather catch things early. Mm-hmm. And there's another argument to this for him, which is, okay, who's on the 3 month? The 3 monthlies are the people that present with fillings every single time you see them. So if I see them and there's 2 fillings, and 6 months later there's another 2 fillings, really I could see them every 3 months. I could talk about prevention. I could put fluoride on those teeth to protect them. I could catch the lesions early and do smaller treatments that are less invasive. So there's lots of advantages for me to see them every 3 months. It could be somebody who's suffered oral cancer in the past, or a lesion that I'm keeping a very, very close eye on. for example, a white patch can present itself, or even a red patch, or worse still, a white and red patch that can often present itself as oral cancer. If I'm looking at something like that, I want to keep a close eye on that. And then the 2 yearly ones would be few and far between. It may be somebody with a full denture, let's say. They've only got their gums. But even then, I'd like to see them every year and a half or so at least, just to check for oral cancer. So it's a risk assessment, basically. And the argument for and against it is, can you see 60 million people in the country as frequently as every 6 months and still make it work financially? So that's the question, isn't it? It's not about necessarily what the outcomes are or what you're trying to catch. I mean, if I saw somebody every day, which would be a ridiculous recall level, yeah, I would catch things really, really early, but it would be a waste of their time and a waste of my time. We'd all agree on that. So where is the happy balance between what's financially best and also what's clinically best? And the people that guide us are called, based on the NICE guidelines. Medics are under NICE regulations, I'm sure, as well, for your prescribing habits and various medicines that you can and cannot use. And they, I suppose, look at the bigger picture and they say, well, okay, I think the recall should be this, and that's the most cost effective. Not necessarily the best clinically, but the most cost effective. I'd agree with that in terms of it being the most cost effective. But as a private practitioner, I'm not necessarily looking at it from that angle. I'm looking at it from what do I think is reasonable in terms of reducing risk levels for this particular patient that's in front of me.
Yeah, that's really good. We've got questions coming in, Seby, so let's take one. I took my father to the dentist last week. This is a listener who said this, and he asked for a tooth to be put in that he was missing, however was refused due to the ongoing COVID situation. Is this something that dental practices have put in place across the UK, or is it up to individual dental practices to decide? Also, when do you think things will be back to normal? I guess this is referring to, obviously, there's so many things going on, aerosol generating procedures, Seby. Maybe if you can actually link that into the answer and what that actually means. And this whole case, I think the WHO said back in August that, only urgent dental care and not for many things, things that are using water, sprays and so on. So in the actual context of those kind of procedures, and maybe just give you some advice to this listener as to what's going on with their father not getting the treatment that they asked for.
So if you've got a missing tooth, there's essentially only 4 options for you to consider. One is to leave the gap as it is, which if it's at the front of your mouth or for various other reasons, it may be unacceptable. The second is a denture. That's a piece of plastic that goes inside your mouth. It's removable, so it moves around and you can take it in and out. But it does the job. You can bite against it and you can, obviously aesthetically, it fulfills its function. The third option is a bridge. That's assuming that the teeth on either side of the gap are healthy and they're good enough to take a bridge. They've got enough support there, so you could use them to support a crown onto those teeth or some sort of fixture, and that would have the fake tooth hanging off the tooth next to it, next to the gap. And then the last option is an implant, essentially. Now, a couple of those are non-aerosol generating procedures. For example, a denture on the whole is not, there's not a lot of aerosol required in that procedure at all. It's impression based and things like that. There may be 1 or 2 occurrences where it's needed, but on the whole, it's not really needed. So without going into the specifics of this person's case, I mean, it's difficult to answer, but they could have a denture, for example, if that was the case. An implant largely is non-aerosol generating as well, but very expensive. So that's the downside of it. Surgery, that's the downside. It's expensive, but has very good success rates over the long term. Dentures, cheaper, non-aerosol generating. And then, the one in the middle, the bridge option, does require aerosol. And, it may be that the dentist hasn't prepared themselves for aerosol generating procedures. It may be that there's a backlog of patients. It may be that their protocols are not quite in place. Although saying that, I think it's getting to a point now where I think we've had enough time, and it's without some undue sort of exception, most dentists should be kitted up at this stage, unless there's some weird exception. By this, we've had enough time now to get the protocols in place, to get the equipment ready. So we should be treating patients, as far as I'm concerned, and treating them to the full effect. Yeah, I mean, it's about reducing risk, and if they're on a 20% target, it could be related to that, in terms of they don't have to do any more treatment. So maybe not back for that. I don't really know what the reason was, but essentially it could be a variety of those sorts of reasons. But the aerosol generating procedures, I mean, yeah, the WHO have said that, okay, we should do the minimum amount possible. The problem with that is, and you guys are finding this in healthcare, is with dentistry, we were always doing the minimum amount possible. It's not like we were seeing people just for the sake of seeing them. And a lot of these things are coming back to bite us. We had 2 months worth of lockdown, and people were pulling out their own teeth, and they had no access to dental care. A lot of those things, had they been treated in the months prior to that, could have been prevented. So it's a balancing act. How many breast cancers are going undiagnosed? How many? There's a greater effect of this thing. So we need once you've got the protocols and the equipment in place, we need to see the people. We need to see them, and we need to see them preventatively. We need to think for the long term. This thing is not going away. It's not going away anytime soon. All we're going to do is amass abscesses, tooth loss, major problems, oral cancer, all of these things just down the road. When is it going to go away? I think that was the second part to your question. I can't see this changing. Unless there's a vaccine that comes out really, really quickly, and is effective and safe. It seems like, I mean, the latest, you guys can answer this better than I can, but it seems like antibodies are not lasting a long time in some people. And if that's the case, then they're liable to a second infection. So we need to treat them as safely as possible, and we're doing the best that we can. Honestly, we really are. Get the fans fitted. The surgeries need the fans fitted. You need to be able to remove that air. But saying that, with all of these precautions, there's not many other countries that are following the same protocols that we are. Nobody else. It's almost business as usual in a lot of other countries. And what we're getting back from these countries around the world is that there is not an increased risk in dental care. Maybe because we're so good at cleaning down. We see so many patients in the day, and we're so good at cleaning in between patients. But the risk factors in dental care, you would assume, because we're so close to the mouth, would be astronomically high. It would be equivalent to, let's say, an A&E doctor who's working with the lungs. But it's not. And it's surprisingly very, very low. We're very good at screening patients before they come in, and we're very, very good at cleaning down. So we had all these precautions in place before, and all we're doing is enhancing them. So I would disagree with the document released by the World Health Organization, because I don't think in the long term it's going to benefit. And where is the evidence to say that we are at high risk? We're not. The evidence is saying the complete opposite, that we're actually very, very low risk.
Yeah, thank you for that. Seby, a very comprehensive answer. And I guess it's just for our audience, whatever advice they do watch and hear, it's for them to consider actually liaising with their own GP as well as their own dentist for ongoing support and treatment. So I think that's important. But it's great to have Seby give his expertise. Questions are flying thick and fast, Seby. So I'm going to take one more and then perhaps move on to cosmetic dentistry. So one of the listeners has asked, is someone with type 2 diabetes more at risk of getting gum disease or not? Also, if someone who has gum disease, can it be reversed through good dental care? So what would you recommend? So
yeah, I mean, gum disease, I suppose there's sort of two forms of gum disease that I would say. One is the patient that presents to you who has clearly not looked after their teeth. So it's related to their oral hygiene, essentially. That's the main cause and the main factor that's caused the problem. In that case, you can reverse that quite easily and quite simply with preventative care, like we discussed. So, scaling. If you go and see a hygienist or a dentist, they'll have a scaler, and they will be able to scale the plaque or remove the plaque and tartar off the teeth. Once the bacteria have gone, the inflammation to the foundations, the gums, reduces down. The gums become pinker, they become firmer. And essentially you've reversed the condition. Maybe not reversed it, but you've stabilized it. Let's say you won't get that support that you've lost back, but you'll prevent it from worsening. Now, the other type of patient that presents to us is one that's genetically vulnerable to gum disease. And these people can be very, very difficult to manage. These are the people that are going to live with gum disease for the whole of their lives. It's a bit like a footballer who suffers a heart attack on a football pitch at the age of 25 in his prime, and sort of dies, basically. You know, that person may have had some genetic basis to their condition. And then you've got somebody else who eats, you know, pork pies for 80 years and nothing happens to them. You know, they have no strokes, they have no heart attacks. And there's a big amount of genetics involved in this. And most people fall somewhere in between. There's a slight genetic component. 40% of people fall into this sort of area where there's a slight genetic component to it, but with good oral health care, flossing, using wire brushes, brushing twice a day thoroughly as your dentist or hygienist recommends. Mouthwashes I wouldn't recommend. Just good brushing, good oral hygiene, seeing your dentist regularly. These people that are genetically vulnerable will have to see the dentist and the hygienist for the rest of their lives every 3 to 6 months, no doubt about it. And we just have to, all we're doing is firefighting, essentially. You know, it's still there in the background. We're kind of just trying to get on top of it, and we're trying to firefight it for the rest of their lives, and trying to stabilize it down. And they may end up still losing their teeth despite all of those best efforts. But we can prolong it nowadays with modern techniques, even a referral to a specialist in gums. We can prolong their teeth, and the inevitable isn't necessarily inevitable, but in some cases, I would say those that are very, very genetically susceptible, it probably is. There's not a lot that we could do. And you were saying about type 2 diabetes. Yes, it's a major cause of gum disease. We know that. And controlling in that sense, it's controlling the blood sugar levels. This is where we talk to GPs. We look at their 3 monthly reviews and their 3 monthly scores. And we check and see how they're doing at controlling their sugar levels. We have to go back to their sugar levels, essentially, to try and minimize it.
Great. And I was just reading through your bio, with your team at Brighouse, and it talks about your interest in cosmetic surgery. So there's that 6 months smiles to straighten teeth. So what options are available for patients who want to proceed down that route? And some people that do have perhaps some dilemmas or ethics related to whether they should proceed down this route. So what can you tell them?
I think the ethics and dilemma, that's a good thing to have. I think in all healthcare decisions, there's a dilemma usually. There's a decision to be made, and that's a good thing. It's not like shopping for windows. It's not like buying a new car. It's not, and even when you buy a new car, you weigh up the benefits and the risks, and you weigh up all of these things, the costs of it, how efficient it is, how safe the car is, and in healthcare, it's a balancing act. It's a risk-benefit ratio. So when it comes to cosmetic treatment, there's certain things that you can do that are quite low on the risk level. For example, tooth whitening. One of the main risks with tooth whitening is sensitivity, and it's only temporary usually while you're whitening the teeth. There's very few other major risks with tooth whitening. So I mean, if somebody just wanted to brighten up their smile and they wanted to do tooth whitening, I've got no qualms about that. That's absolutely fine. But you could go to the other extreme where people are, for example, going to Turkey and going abroad and having what they think are veneers. And I've had people return to these countries and they're not veneers, they're crowns in a lot of the cases. And the difference between a veneer and a crown is that a veneer covers usually just the front of the tooth and it's a minimal preparation, whereas a crown is usually a heavier preparation. It covers a lot more of the tooth surface. And these are people with virgin teeth, so these are healthy teeth getting ground down, getting very close to the nerve of the tooth, and that will later die, possibly, needing root canal treatment or implants or extractions later on. No doubt the patients return happy with the initial look. I'm not disputing that for a second, but could that same look be achieved through much less intervention? And I think it can. Whitening is one. If you whiten your teeth for long enough, you can get them pretty white. If you have a good cosmetic dentist, you can build up the teeth and make them look almost like veneers. Whereas all you've done with composite is you've hardly shaved the tooth down usually. You've done very minimal preparation. All you're doing is adding to the tooth surface in the areas that the tooth is missing. So if you have chipped, worn edges, you're adding to the tooth surface essentially. So additive dentistry is where I think, and modern bonding techniques to tooth, that is where I think dentistry nowadays should that's where it should be. Cosmetic dentistry should be in the whitening, aligning teeth. So aligning teeth has risks, but you're actually moving physical teeth around that are the patient's own teeth. And so long as it's done carefully and in the right hands, the risks can be mitigated and reduced. And so a lot of modern dentistry, and this is the dentistry that I like to improve smiles, is moving teeth around that need to be moved with Invisalign, let's say, or 6-month smile, or any other brace system. There's lots of systems out there. And then whitening the teeth, and then composite just to finish the case off. Just any little chips and wear, just finish it off with a bit of composite. Composites do have a lifespan, 7 to 8 years, and they'll need refreshing. But effectively, it's adding to the tooth surface every time anyway, almost. Veneers, if need be, in the right cases, veneers are appropriate. Usually teeth that have worn down a little bit, and there's a lot of change that needs to be made. And yeah, I mean, that's my take on cosmetic dentistry. I think we need to think hard and fast about it as professionals, what we offer patients. Let's not make it a selling exercise. Let's have a discussion about risks and benefits. What is the patient looking for? And I've had patients return back with horrific dentistry that we're having to correct. And patients need to be fully aware of what they're doing when they go abroad or when they do these things. Because how do they complain, right? I mean, who's regulating these people? Are you going to get on a flight and go back? It's crazy.
Yeah, well, you get what you pay for, isn't it?
I think so. I think that saying is true in healthcare. I think healthcare. I think price in healthcare. I mean, me as a private practitioner. I mean, imagine you guys as doctors having to, every single time you need an intervention, you need to take an X-ray of something, or you need to refer. You're saying, okay, there's a charge attached to that now. I need to write a referral letter. I'm going to charge you £10 for that referral letter. There's a big dilemma there, right? And you have to do that. And you have to, as dentists, we have to do that. But I think the patients are just unaware of prices. And I think that's the fault of us guys as well. We don't communicate how expensive these things are and how expensive it is to run these teams and buy the equipment and keep things clean to modern day standards. We're regulated so heavily. We have to abide by all of these rules. And I think patients should be more aware, and I think they're having to become more aware. I think that crunch time, it should have happened in 2008, 2009, to be honest with you. We knew what was on the cards with austerity, and we knew that this lack of investment was going to happen, and we're in the situation that we are now with long waiting times and difficulty. And coronavirus has just accelerated and perpetuated those problems, and the cracks have opened up. But patients are now aware. They're buying their own equipment. Healthcare workers have a level of respect. We need to really have this debate. This is the time for that debate to happen. How much do things cost? Do we increase taxes? Yes or no? Do we go to a core service? Do we offer less? Is the NHS not an all singing, all dancing affair anymore? Is it just a core service? And dental as well. Is it just extractions? If you see an NHS practitioner, is it just extractions and a very basic dentistry done? And if you want something a bit more advanced, if you want a bridge, you want something a bit fancier, you have to then pay for that privately. We need to have that debate because the equation has to balance, and there's no point politicians kidding themselves, there's no point patients kidding themselves, and there's no point professionals going along with a big lie. We have to face the truth for what it is, and that's the only time that we can come up with solutions once we know what the truth is.
We've only got a few more minutes left, Seby, so I'm going to just drill down further, forgive the pun, on this topic on cosmetic dentistry. Just for the audience, just to remember, cosmetic dentistry is generally used to refer any dental work that improves the appearance, though not necessarily the function, of teeth, gums, and or bite. And it's also important, I think, and useful to know that the American Dental Association does not recognize cosmetic dentistry as a formal specialty area of dentistry, but there's still dentists dentists who actually promote themselves as cosmetic dentists. And the reason I mention that is it links into a question we've had, Seby, where has cosmetic dentistry become too commercialized? Can you link that into the definition of cosmetic dentistry and then help answer that listener's question?
Sure. Yeah, I mean, cosmetic dentistry, like you said, is mainly to do with the appearance, but often in cases of cosmetic dentistry, you're actually improving the health of the teeth at the same time. So, for example, if you have worn, we talked about worn edges and composite. The composite is adding to that tooth surface and protecting it from further wear. So it's not like it's one or the other necessarily. It's not health versus cosmetics. It can actually kill two birds with one stone in a lot of cases. So adding composite, moving teeth in the right position can sometimes help the function of those teeth. It can sometimes help the hygiene of those teeth. If teeth are crowded, it's harder to clean those. So there are certain health benefits that can arise out of these treatments. Sorry, I forgot the second part to your question there, Fahim. What was the second part?
Yeah, it was about too commercialized or not, they were saying,
Yeah.
and obviously, yeah.
Yeah, sorry. Yeah, I mean, in terms of too commercialized, I agree. I think that I often have to. I mean, it's a bit of a funny situation because I promote myself as a cosmetic dentist. You know, that's how I get people through the doors. Not everyone, but that's how I get people. But whenever they come through the door, I have to then educate the patient in such a way that I'm bringing it back to health issues, and I'm going back to this issue about killing two birds with one stone. And it's tricky for me because I'm trying to get them out of this sales pitch environment, and I don't want them to think that this is a sales pitch and they're going in to buy a Lamborghini of a red color with such and such interior. It doesn't work that way. Teeth don't work that way. Healthcare and people's bodies are very unique and they're very bespoke, and they have their own problems and risks and benefits. And I like to talk about risks and benefits. What is the patient looking for? And when it comes to cosmetic dentistry, there's an element which is very, very commercialized, and you can see it on TV now, tooth straightening and all of this other stuff done by companies that are dubious, in my opinion. I think trust your dentist. Find a dentist that you trust, stick with them, make sure that they're qualified and they've had the extra courses that they need to go on to be able to provide the treatment. And just see what they've got to say. And if they're saying it in a genuine way, they should be talking about risks and benefits. They're not trying to sell you something. It shouldn't feel like a sales pitch. It should feel like a mutual decision is being made. Like I'm giving you some information and you're taking that information in, and then you're thinking, okay, maybe I should do this or that. Not this is what you should have done. This is amazing. This is so I don't think that I think the premise of the conversation can sometimes be wrong on both parties, both patient and dentist, and it needs to be redressed. But yeah, I think on the other hand, I think we can undersell ourselves as well. I think there's a lot of benefit psychologically from having nice teeth, and we shouldn't undersell and understate that psychological benefit. People are more confident with their partners, with meeting people, with their confidence with job interviews, with socializing. How do you quantify that, right? Do you quantify that as a millimeter of tooth removal or 2 millimeters, or how do you equate that? It's not a straightforward balancing act. If I take 1 millimeter of tooth away, it's going to enhance your psychology by 20%. What is the equation? It's an impossible equation. You just got to take the patient's words and utilize that and come up with a medium that you're happy with.
Yeah, no, I completely agree. Talking from personal experience, my late great uncle, he said when he was meeting his future wife that he was spotted there smiling their teeth first. So I think for matrimonial and other purposes, teeth is really important. Linking into what you said before is another question. You talked about getting a good practice. And I think that's an important question. We're at a crossroads in many ways. People are deciding, well, maybe I don't want to be at the same dental practice I've been in because I've not really seen them for the last few months. Okay. So with so many dental practices open, more choice, how would you recommend to people listening in how to find a good dental practice and a good dental surgeon? What should they look for? Because for the general public, you talked about qualifications, but it just might be letters at the end of the name. They don't know what that means. I wouldn't know what that means, Is it the number of awards they have? Is it just word of mouth? Is it a good website? Is it everything? How do you decide what's a good dentist?
I think that's a really tricky one to answer, actually. How would you shop around? I think word of mouth is always a good place to start. So if you know somebody who knows a good dentist who has had good dental treatment, I think that's probably as much as a lay person could probably get involved in. Awards and everything, I think you mentioned we were the finalists in some categories and stuff. They are absolutely meaningless. Letters at the end of your name mean something. It means that you've studied hard and that you are qualified on paper, but in practice, dentistry is a very hands-on, dexterous profession, and the abilities, the skill level that you see in people's hands differs, and that's just the nature of surgical care, really. Surgeons differ. Their knowledge might be higher, but their skill level might be lower. Experience counts for a lot. So, what would I be looking for loosely? I'd be looking for somebody in the middle of their career. So in their 40s and 50s. That doesn't mean that's not a hard and fast rule. And that just means that they're young enough to keep up with stuff. But they're old enough to have some level of experience. Experience is just a number of failures, right? Over the years, the number of failures that you've learned from. So that's important to be able to see, and to pick a dentist that talks to you in a way which isn't salesy, which isn't telling you off, which is just trying to get to the root of a problem. And then word of mouth. And then as guys within the profession, we sort of know who's good and who's not, and also know whose skill levels are and expertise in certain areas. And we spend thousands and thousands picking that right dentist to make sure that they're available for us, because we know their skill levels, we know the materials that they're using, we know this, the stuff that they do is almost impossible for another dentist to recreate. So I think it's a tough one for him. I don't think there's an easy answer to that for a layperson to just say, okay, here's a website, top 50 dentists in the country, all of the awards, all of these top 50 categories and stuff, throw it in the bin. Obviously, it really isn't like that. It's a tough one. It's a tough one. Pick someone that you trust. Pick someone that gives you the information that you're looking for. But do be willing to pay for that, because these people know what they're worth as well, and they know that they've worked hard. They've spent thousands. I mean, I've spent probably 40, 50,000 just on dental courses. I didn't need to do that. I could have charged slightly less for my patients and not done the courses and not offer them good treatment. But I chose to offer them excellent treatment because I've invested, and that needs paying for somehow. 40, 50,000 pounds doesn't just come out of my pocket; it comes out of the patient's pocket, because they're benefiting from that experience. They're benefiting from that, right? So it's them that are paying for that, and that means my day book is booked, and it's fully booked because they appreciate that.
Great. And just before we go and Mehran closes the show, teeth whitening products, tell us are they worth it or not? I think we've had so many questions on that. Just give us an answer.
No. Unless you're going to see a dentist, the peroxide levels in products that are in the shops, I think it's about 0.1% or something like that. The stuff that we give you is anywhere between 6 and 16%, or 10 and 16%, depending on the solution that we give you. That's going to whiten your teeth. Even then, it takes 2, 3 weeks, 4 weeks of nighttime use to whiten your teeth. A toothpaste on your teeth is going to get rid of external stains, is not going to change the physical structure and the physical color of the teeth without this peroxide at a certain level. Dentists are the only people that are legally allowed to do that. So if you go to a beautician and they say, let's do some tooth whitening, it's illegal. And if it's illegal, it means that they're unregulated. If they're unregulated, they can use whatever they want. They're not aware of the dangers of that. They're not aware of the risks. They've not checked your mouth. So no, it doesn't work. Everyone wants a quick fix. And in tooth whitening, it's not a quick fix. But to be honest with you, it's the cheapest, most effective cosmetic treatment you could have done. For a couple of £100, a few £100, you've whitened all of your teeth and you've not damaged them in a professional setting. Just get it done properly.
Thank you. Great way to finish off. Mehran, if you can close the show for us. Thanks for coming on tonight, Seby.
Thank you. Thank you for him.
Thank you. So next week we've got Dr. Aglan and Sana Khan, who's a pharmacist, to discuss all things related to pain and pain management. So it should be a really interesting and insightful show. So please do join us on Tuesday, 8 till 9 next week. But Seby, I'd just like to thank you again. I like how you squeezed yourself in between the 40 and 50 age range there. But But it's been a pleasure to have you.
It wasn't a plug, honestly. It was. No. Thank you for having me on. It's been great.
Thank you, Seby.
Take care, everyone.
Take care.
Thank you.
Thanks.
Take care. Thank you. Bye.
Bye.